Hi everyone, welcome back to Neurospicy Nursing. So this is the part two of that cardiovascular lecture that is already live on the channel. Um, but this is a little bit more in depth um, on this material rather than just kind of covering base, like the baseline of it. Okay, whoops, went too fast. There we go. So there are this one's a little bit more anatomy based, by the way. There are different layers of your heart. And if you can remember the mnemonic EME, exterior muscle endo, which can also help you remember epicardium, myocardium, endocardium. So your epicardium is your exterior layer, myocardium is the middle, and the endocardium is that inner layer or the lining of your chambers. And then your pericardium, just remember peri, ouch, P and P. The pericardium is the little sac around your heart. Um, that just, it's all the parietal and visceral layers, and there's fluid in there for lubrication of the heart. And then your chambers. Your atria are the attics, they're the upper levels. Your ventricles are the vaults, or the lower levels. So, all in all, please don't forget that all layers of your heart can be affected by an infection. Okay, so make sure that you think that or remember, infections don't discriminate, so they can attack any portion of this heart. Oops. Okay, so your blood flow. Now, you can also remember the mnemonic. Try pulling my aorta or kind of listening to things. Or like, for example, in the way that blood flows. So things go from the tricuspid valve, well, aorta to the tricuspid valve, or sorry, let me back up. I said aorta, I'm sorry. Atrium to the tricuspid valve, then to a ventricle, then to the pulmonary valve. After the pulmonary valve, it goes through the lungs, then it comes through your mitral valve, well, left atrium, mitral valve, your left ventricle, and then to the aortic valve. So try pulling my aorta. We're just talking about the valves and the areas, like what order they go through. Tricuspid, pulmonic, mitral, and aortic. So your right side is your deoxygenated blood. Your vena cava, your right atrium, tricuspid, right ventricle, pulmonic, and then the lungs where it's going to get the oxygen. Your left side is the lungs, left atria, mitral, left ventricle, aortic, and then the rest of the body. Your arteries are going to carry blood away from your heart, away. Veins visit the heart. There's only one exception to this rule, and that is your pulmonary artery, still carrying blood away from the heart, but it's deoxygenated. And your pulmonary vein is still carrying blood to the heart, but it is oxygenated. So make sure that you know that that's the only time where it's different. Okay, so cardiac output, preload, contractility, and afterload. Now, if you guys can remember that your cardiac output is equal to your heart rate times your stroke volume, you're going to be good. It's basically telling you how strong your vehicle is. This is your horsepower, all in all, when we're thinking of cardiac output. It's your body's own horsepower. So, ventricle. Ventricles are important for our preload. If you're thinking of the preload, just remember that your ventricles are the blood filling in them at the end of diastole. So it's pre-stretch. Preload is pre-stretch. Contractility is how strong that squeeze of the heart is. And afterload is how hard the heart has to push against all of the pressure from the rest of the body. And then we have ejection fraction. So if you can remember, EF is ejecting fine. That means you have a good ejection fraction, and the normal ejection fraction is 50 to 70. I think they upped it now, and it's actually 55 to 70%. But if you remember 50, 70, you're pretty much golden. Okay, so hemodynamics. Now remember, CVP, or central venous pressure, is the pressure of blood that's returning to that right side. It's supposed to be between 2 and 8 millimeters or millimeters of mercury. Your map is what's important or what's needed to perfuse your organs. So this is kind of like that average of your diastolic and systolic kind of put together, and that's how you get that number. And you need at least 60 mmHg to perfuse your vital organs. So if we start dropping below 60, that's a red flag. So if you can remember that a map greater than 60 is the map for life, because that's exactly what's happening. Without anything greater than 60, our organs aren't going to be perfusing properly. So when we don't, life may not happen. So LDL. Our LDLs are bad cholesterol, so we want LDL low. HDL is the good cholesterol. We want HDL high. And BNP. If you can remember that BNP is for the ballooning of the ventricles, because it happens when your ventricles stretch, then you're golden. And then ANP is the same thing, but for your atria. And your D dimer is just helping tell us whether or not they can have clots that are present. Okay, so we already kind of went through this, but I am just gonna tell you guys again that the lower we go in the heart's conduction system, the slower we go. If you are having a difficult time remember this, go watch the other video I just posted again and really focus on this section. But the lower we go, the slower we go. Okay, so this is just a little bit about your EKG basics, because we've talked a little bit about it. That P wave is going to be responsible for atrial depolarization. Your QRS complex is your ventricle depolarization as well as your atria repolarization. And your T wave is your ventricle repolarization. So if you can remember, the PQRST is the pump, squeeze, then chill, because your ventricles are repolarizing and relaxing at this point, then you're good to go. All right, congestive heart failure. This is when your heart muscle can't pump enough blood to meet your body's needs. And it either is going to flow back into your lungs, so that's when you kind of have those left-sided heart failure signs and your, lack of a better term, drowning in your own lungs with orthopnea, dyspnea. You see that frothy sputum, all of that stuff. And if the other side starts failing, you get to see your edema, your JVD, ascites, fluid in all places where it's not supposed to be. There are risk factors for this, like hypertension, coronary artery disease, a previous MI, arrhythmias, and if someone has valve issues like stenosis, or and it's not just stenosis, even regurgitation and stuff like that can cause it. So, going back to your BNP, we want our BNP to be less than 100 because that's how we know that our heart isn't stretching in response to too much fluid. If they have a BNP that's well over 900, that is very severe heart failure. So again, BNP stands for the ballooning, right? The ballooning of that fluid. You can also call it the ballooning number predictor if that helps you. But it actually stands for B-type natriuretic peptide. So make sure that you remember that, sorry guys, my phone is ringing. Make sure that you remember that the best way to monitor for heart failure is going to be weight. And weight equals water. So if they gain more than 2 to 3 pounds in 24 hours, they are having a heart failure exacerbation. So we talked a little bit about this in the previous video, but please don't forget crackles, orthopnea, dyspnea, pink frothy sputum, chronic cough, cyanosis, frequent lung infections are all going to be associated with left-sided heart failure. Right-sided heart failure is associated with JVD, ascites, hepatomegaly. Sometimes if we have hepatomegaly, they can lead to other things like splenomegaly, or they can end up with a hiatal hernia. And that's just from all like the enlargement of those organs pushing up on the hiatal area of the body. Okay, so coronary artery disease and angina. So both of these are basically going to be caused by arteriosclerosis. Coronary artery disease is the narrowing of the vasculature around the heart, and it's going to be limiting it's the heart's own blood supply. It also has risk factors like high cholesterol, which makes sense with arteriosclerosis, smoking, obesity, and hypertension. And angina is chest pain because of ischemia. So if you remember in the last video, we talked about ischemia is the reduction of blood flow, and infarction is also reduction of blood flow, but it's leading to cellular death. This is just reduction of blood flow that's causing the pain. Stable is going to be predictable. We know that if we exert ourselves, we're going to get the chest pain. If it's unstable, it is occurring when they're at rest, and it's going to lead to them having an MI. Variant means that it's a spasm of the coronary artery. So making sure that we know that this here, the blockage, see we have the narrowing from the arteriosclerosis. If we have anything like in this piece, a plaque ruptured and then it caused blood and then the clotting, this isn't a medical emergency, right? Because they're going to have tissue death on, like I said in the last video, it's like a straw. If we have a full blockage, this side, this side, this side, and behind it, it's all going to lead to necrosis, right? Versus if this was an NSTEMI, let's say this side isn't here, like this lower piece isn't here, they're only going to have cell death wherever this area is, okay? So they will have that sudden crushing chest pain. They can have radiation to their jaw, shoulder, their back, their epigastric area. They can be diaphoretic. They can say things like, I feel like I'm gonna die. All of those are signs of an MI. Oops. And again, women, we have the more atypical signs like epigastric pain, which can actually delay the diagnosis. So if they say, like, let's say they don't have any chest pain, they just have epigastric pain. All in all, depending on their age and their past medical history, that's when we might want to do the EKG, right? Just to rule out PMI. So again, this is what I was talking about in the last video. The STEMI is the ST elevation. You can see that elevation here. And the NSTEMI is the depression. And this is the treatment that Mona B, or just Mona in this case, a lot of times do. We give a beta blocker just to reduce their blood pressure that they'll have because they'll have an elevated BP. Okay. This is more on those cardiac biomarkers. Troponins are going to be the best indicator for if someone has an MI. And creatine kinase is also important to test. But the difference here is that creatine kinase it's not as reliable. It peaks a little bit differently. And also, the other thing to keep in mind is that you can have an elevated creatine kinase if there is other types of tissues that have been affected, versus troponin is more based on actual heart muscle damage. You can have creatine kinase if your kidneys are damaged. And then myoglobin. myoglobin, it's not a specific indicator, but if they have, since it does rise the fastest, if we test it and it's negative, there's probably a good chance that they're not having an MI. So don't forget that troponin is trustworthy and it stays for 2 weeks. If you can remember that mnemonic, then you're good to go. CKMB rises and falls faster, and myoglobin is minute by minute. Remember, it really increases very, very quickly and then falls very quickly, and it's going to be kind of the first indicator for an MI. So AFib versus VTAC. So just remember that AFib is kind of a fluttery mess. This is a mess. It's irregularly regular, like we talked in the previous one. It's disorganized, your atria are quivering, and that quivering can increase your risk for clots. So they may have stroke symptoms, PE symptoms, or even a DVT. VTAC is also kind of a mess, but it can actually happen in someone who is pulseless. And just remember, it's like tombstones, which means that it's very fast and very dangerous. So it can actually lead to death. Cardioversion versus defibrillation. So this is when a synchronized shock is delivered, and this is when a shock can be delivered at any time. A lower level of joules is going to be used for cardioversion. A higher level is used for defibs. These are for stable patients who have a pulse, and these are normally for pulseless patients who have a need for resuscitation. Cardioversion can be for AFib, and these are for VFib or VTAC. Defibrillation is for deadly rhythm, so remember that. And cardioversions are carefully planned in a controlled environment. These are just some medications that we can use for antihypertensives. Diuretics, normally, like when we're thinking of diuretics for antihypertensive usages, we're thinking of our thiazide diuretics can be like a first line treatment for them. Some of these are more heart failure related. Spirulactone is a potassium sparing, and potassium wasting is furosemide. So we have to make sure that we're monitoring those levels. But for hypertension, well, the reason why these lower hypertension is because we're getting the fluid off of them. But enalapuron, which is a potassium sparing, and some other thiazide diuretics can actually be used as a first line treatment for hypertension. Okay. So that is it. And the last thing I want to leave you guys with is just remember, if you can understand that your heart works like an engine and you can help find the issue in that engine that leads to the malfunction, these mnemonics are going to help you remember it long term. Okay, so just remember these mnemonics. It's going to help you. They seem like a lot. It is a lot, but they are important, and it's going to help you get through your test a lot easier. Okay, that is all I have for you guys today. We went through this one a lot faster. But again, no case study on the previous one. There is. Just type in your comments about it, and I'll just let you know that you guys are on the same, if we're all on the same wavelength, right, when we're thinking of the case study. I will end up posting a quiz on this material. Just give me a little bit. I'm going through my preceptingship right now, so it's been a lot. And at the same time, I'm trying to help you guys in my last semester because teaching really helps me make sure that I know what I'm doing for the NCLEX, and if I can teach it, I know it. But it's also helping you guys in the long run. And then I will still hopefully be doing this when I become a nurse, which would be great, and hopefully very soon. So just bear with me. I know there hasn't been a lot of content recently, but I'm getting back into the swing of things and really want to make sure that I can do this for you guys. Okay, have a great rest of your day. Study real hard, but also give yourself grace. Have a great day. Bye, guys.